Well, maybe, we don't know for sure. This is certainly the fracture here. We can see the fracture. I can tell you for sure that that's the fracture here, and I think that's what's causing you the pain. There may be some bone marrow infiltration at the levels below, but we don't know for sure. Those could also be benign tumors, sometimes completely normal. So all of us, we could have some kind of benign tumors there. I cannot say for sure that that's because of his underlying disease.
But there's a fracture in there.
But what I can tell you for sure is that there's a fracture here. The end plate, this is what we call the end plate, is fractured. It's pushed down. And I think there's a very good chance that that's what's giving you the pain. And the treatment, like I said, is conservative pain management time, sometimes a brace. If the pain doesn't get better, then we start thinking about a vertebral augmentation procedure, which is essentially either the kyphoplasty or the vertebroplasty, different ways of doing this. Okay? And the kyphoplasty is a procedure where we make two little holes in the back, basically just needle sticks. We go in with needles and we inject, we inflate a little balloon. The balloon creates a cavity in the bone. Sometimes the balloon also reduces the fracture, brings the bone back to its original height, and then we inject cement, which is what the dentists used to use a long time ago. It's called PMMA. It's a methyl methacrylate cement that we inject in there, and that cement kind of goes into the bone, fills up the cavity, and stabilizes the bone, and that basically treats the fracture at that level. Okay? The other way of doing it is not to use the balloon, but just go in with needles and just inject the cement into the bone.
Yeah.
Okay. Usually what we do, we recommend the kyphoplasty person. Well, kyphoplasty also gives you a chance to actually reduce the fracture.
Right.
The vertebroplasty also works very well, but that's really just a way of stabilizing the bone without reducing the fracture.
Well, I think Nizvitsky said that he wanted to do, or he recommended the kyphoplasty.
Yeah, that's what we usually do. It takes about 45 minutes or so. It's a very straightforward procedure.
What's the recovery time?
You go home the same day or the next morning. Everybody's a little different.
And how about, how long before you can move around? Or
it heals. The cement heats up and then hardens within half an hour. It's completely hard, and then you're ready to do whatever you need to do.
Really?
Amazing.
Yeah.
Wow. So when do we do this?
I don't know. Whenever we would have to talk to Dr. Nizvitsky and make sure your blood counts, your coagulation is fine. We'd have to.
We're doing more blood tests tomorrow.
Right. That's one of the things. Like every surgery, we do it under general anesthesia. You'd be positioned on your belly. Like every operation, there's a risk of surgery and anesthesia. Okay. Overall, this is a very safe operation, but we're operating close to the spinal cord, so there's a very small risk of spinal cord injury.
Yeah.
There's a small risk of injury to the nerves that are coming out at the sides. There's and then there are there's a risk of infection, bleeding. Obviously, in your case, that would be bad if there was any bleeding because the spinal cord is close by.
Right.
The internal organs right in front of the spine. There's a possibility that it may not work as much as we want it to work.
Right.
If we stabilize that part of the spine and you have problems at the level above or below, there's a possibility that those levels may get worse at the level above and below, because suddenly that bone is very solid and very strong, and the bones above and below are soft. Some people are concerned that may, accelerate the, fracture process and degeneration at the levels above. There's no firm evidence for that.
Right.
That's a possibility.
But it's a risk worth taking, it sounds like.
I think if you're in a lot of pain and you failed non-operative treatment, including medication, obviously the chemotherapy and so forth, in terms of the pain, and then I think and we know there's a very good correlation. You have pain exactly at the fracture site on exam, and you have this MRI scan that shows that there is swelling there and the fracture. I think there's a very good chance that this is going to help you a lot.
And what about, I thought that they said there were some areas of disc herniation as well. Do you see that?
Yeah, there's some herniated discs here, but those are, that's at your age and with everything, that's completely fine.
Yeah, where is that at? Would I need to be treated for that, or physical therapy or anything?
No, those are asymptomatic usually.
Oh, okay.
And your neurological exam is fine. You don't have any signs of spinal cord injury or pressure on the spinal cord, which is important, obviously. You don't have any pain radiating. Do you have any pain radiating around your chest?
No.
So there's
No, it's pretty directly related to movement,
Right.
I would say. So is that what we're thinking of doing?
Well, I think that if you feel like you've tried everything else, and it sounds to me like you have, you're taking Percocets, or?
I'm taking OxyContin and Vicodin, and I mean, right now I'm on 20 milligrams of OxyContin, and I took a Vicodin this morning, and I can't get up and out of a chair without being in pain.
Right. I think if Dr. Nowitzki, if they clear you for surgery, if your blood counts are fine and everything, then we can certainly do this.
How soon do you think I'd be able to have this done?
We'd have to talk to my nurse, but I guess maybe next week or so.
Next week?
If you want.
Wow. Cool.
All right.
You guys have questions?
No, he's pretty good.